I love the command I have over a room. Yeah. Good morning, everybody. The Finance Committee will come to order. Any citizens wishing to address the committee this morning? There not being any signed up, we'll move on to item number 3, the approval of the minutes. Everyone's had a chance to review them. Any questions, any comments?
Why, are you asking why we go up there?
My.
Well,
Wow, that's disorienting.
Let me see if we no disrespect, but that's too big, Steve Montgomery.
Amen to that. So we have a motion on the minutes, a second?
Second.
We have a second. Any questions? All in favor, please say aye. Aye. Opposed? Motion passed. Motion, no,
they photoshopped
no
it
no's? Good deal. All right, item 4, CFO report, Ms. Clark.
She could have a news person that cut off.
Good morning.
Good morning. How are you?
I'm well.
So I just have one item on the CFO report. You may have noticed that on the board portal, we have the Hilltop Quarterly Investment Report for the March 31st quarter ended. If you have any questions, feel free to contact me after the meeting. It's in the libraries under the investment folder. So if you have any questions at all, please let me know. There's nothing really unusual to report this quarter, with the exception that the investments are up, mainly because of the tax receipts. The January, February tax receipts drove those investments pretty high, but they'll be dwindling down throughout the next quarter. Do you want me to move on to the policies?
Yes, ma'am, please do.
Okay.
Item 5.
Yes.
Do we have to vote to accept the report? As extensive as the report was, I guess we'd accept it. I forgot what we do in that. I've only been here a couple of years, so I don't remember exactly what.
The CFO report?
The CFO report?
Yeah, it's just information only.
Got it. All right. Item number 5, please.
There are 2 policies, the signature authorization and the employee travel and expense reimbursement. The first signature authorization, I wanted to let you know there's not a lot of changes in this. The major change, there's actually 2. The first one, we added language that would allow us to incorporate effectively a claim into the policy. And we have a management services agreement with a claim that allows us to provide financial services, human resources, employment, and other services. So there is language that was added that allows the district under a professional management agreement to provide these services. And then we also increase the manager signing authority limit in the procedures section, which the board is not responsible for approving today, but has been attached for your review, from $1,000 to $5,000 for expenditures. And then for patient chargeable items, $5,000 to $25,000. Just because of the sheer number of purchase orders that go through, we feel like that's appropriate under these circumstances. And I think these have to be done separately
Yeah.
for approval.
Yes, sir.
Karen, on that change relative to the capital expense increase in that cap, is the assumption there that that would still be within a budgeted item?
Could you turn your mic on, sir? Thank you.
Did you hear me?
Yes, I did hear you.
Okay.
So the expenditure increase has, the managers don't have any capital authority whatsoever.
Okay.
This would just be on budgeted expense items.
Okay, so
or
it's-
items within their budget approval.
That's what I want to make sure of.
Yes, yes. Are there any other questions? So what we're asking for today is just the approval of the policy in your board portal for
Right,
the
we just do
signature.
policies, you guys do procedures.
Yes, the procedure is attached per your request, just as reference.
Right.
Move approval.
We have a motion by Reverend Emerson,
Second.
second by Mr. Petty. Any questions? All in favor, please say aye. Aye. Opposed? Motion passes.
The second.
Item B, please.
Yes, the second policy is for travel, everybody's favorite policy. It has a very similar added language to incorporate additional entities that we have under a professional services agreement, such as a claim. We also made a major modification because the travel policy had not been updated in several years to actually separate the policy from the procedure. It, in its old format, had been one, so you see that change in this policy. And then the major change in the procedure that is attached is we used to have 90 days to submit all the expenses after you came back from a trip. We shortened that to 30, which is more than adequate. People tend to lose their receipts after a period of time. So after you come back, you do need to get those back within a month. So that was really the only change to the procedures, just for your information.
Nothing in there requires people to drive their trucks to Canada or something.
No, and Canada would require the CEO approval as an out-of-country
Out of country,
trip.
all right, international
Just
travel.
FYI, if you'd read the procedures. But,
Yes, got it.
we do not require automobile versus
Automobile, all right.
air
It's an
travel.
option.
Ms. Clark,
It is an
stop
option.
humoring him. Just go on. Just go on.
Okay.
Any other questions for Ms. Clark on this policy change? I'll entertain a motion.
Move approval.
Motion by Ms. DeBose, second by Reverend Emerson. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you. All right. We want to move into item 6.
So, on to the financial report. Let me move my water, that would be bad. That bottle is not looking good. That's better than last month. Okay. So, we had a very strong inpatient month for April. When we get to the outpatient, it was a weaker outpatient month for the network compared to budget. So inpatient admissions, you can see, were up compared to budget about 6.5%. We had 2,098 admissions. Patient days were strong as well, up about 3.5%. CMI was up, or just slightly down compared to budget, and length of stay was slightly down as well. Our ED visits were high, about 5% above budget. Although we had budgeted to be extremely high, we had over 10,700 visits this month. It was slightly below last month, but it was still a very, very high month in the ED. And you can see that urgent care was very strong. Urgent care was actually almost 5,300 visits in addition to what we saw in the ED, and 12% over where we expected them to be. Our clinic visits were slightly under budget by 2%, and outpatient visits ended up settling in just over budget. So observation days came in about 14% under budget, likely due to the strong inpatient activity that we saw, because Observation days do take up inpatient beds, just like admissions do. Invasive lab cases continue to be very high. Inpatient surgeries and outpatient surgeries both were about 4.5% under budget relative to where we had thought they would be. And psych inpatient also ended up being right on budget, about 1% ahead. And the clinic visits are going strong at about 6.5% above where we expected them to be during the budget process. Although psych ED visits were under budget by 1%, they are at the highest point they've been at this year, year to date through April. And partial hospitalization visits are also strong.
1 second. Dr. Weber
I'm
has a
sorry.
quick question.
Are you having to board people
Could you turn your mic on, please?
psych
We
ER?
we
like
do.
there is down there?
Yeah, we have, we do board, and for those that are in the audience or those listening, boarding, the challenge that we have with that is we become so much more efficient and effective at seeing people and triaging them in the ED, but the admit on the inpatient bed is a challenge because we may not have that bed ready, so we oftentimes have to board patients down there and make sure that they've been seen in the ED, but we have a lag to get them into the patient admits. So yeah, we are boarding. We keep track of that very, very closely. Wanda and her team and Chris, the manager down there, does a great job of trying to figure out how we open up. We work with our hospitalists to free up those beds best we can. But it's a challenge.
Do we have to ship people?
Shit.
Like Wichita Falls or any other place in town? Or?
No, sir.
Okay.
For inpatient,
Well, 1 second before you answer that. Wayne?
I thought he was asking about psychiatric emergencies.
Are you talking about psych emergencies?
Yeah.
Okay, I'm sorry, I misunderstood. My mistake. I gave you a whole description of something you didn't even ask. Wayne, do you want to talk very briefly on that issue so we can address Dr.
We can do
Weber's
it later.
issue? No, it's fine. It's a good question, and since I answered it wrong, I'd like to get the correct answer.
Call someone up if we're looking for correcting.
This Harry Truman is the proverbial buck stops at you now, so please.
ER down there?
Yeah, I misunderstood.
We also do have boarding in the psychiatric emergency center. As you know, we opened a new facility 15, 16 months ago. We filled that up in a couple of weeks. We admit about 4,000 people a year through our psych emergency center to our facility. We transfer out to other facilities about 3,100 patients a year because of our lack of capacity. And so we do send out almost equal number of people to other hospitals as those that we admit to our facility.
Okay, well, here's my finance question. Who pays for all those people that we ship to other places?
So we have contracts with 4 different facilities. We do not pay for all 3,100 of those. Many of those 3,100 have insurance, which is a lost opportunity for us, but it's not an expense for us. There are several hundred that actually do not have a funder, and in those cases, we have paid, last year we paid right at $3.1 million to those other 4 facilities through contracts that were approved by the board that came through this group.
I guess the next step would be, I mean, are the private places just taking the insured? They don't take any JPS connection folks? It's an area I don't know anything about.
Sure, I understand.
So if they show up at their facilities, they certainly have charity care and the same obligations that any hospital has. The challenge for us is if they show up here and our psychiatric emergency center begins to fill, which happens daily, honestly, and the boarding starts to escalate, there comes a point where there's no way to safely maintain the volume of people in our psychiatric emergency center that is there. And so we have to find a way to have a backdoor so those people can flow out. And the way we have to manage that is through those contractual relationships with those other 4 hospitals. Like I said, to the tune of about $3.1 million last year.
And this is an area where you, without, my attempt is not to be persuasive, I'm just telling you that this is where the population growth sees significant impact to JPS because there are not a lot of alternatives
Right.
for these type facilities. So JPS is the place that needs to handle the bulk of that population. And part of that is facility growth in trying to deal with a population that is significantly growing. There is no choice. We have to look at alternatives best we can, but those aren't very viable. The place and the answer is JPS and its expansion and its facility growth.
And the process to transfer those individuals to the hospitals, allow the law enforcement transports to happen, that is a long time. It's not quite as quick. If they're voluntary, we can send them via EMS and get them over there relatively quickly. But if they're involuntary, there's a whole process that has to happen, which ultimately adds to, they end up boarding here, waiting for an admission there, about 19 hours while we're waiting on a bed for them.
This is going to come up in Blue Ribbon,
Yes, sir.
without question, because there's been so much discussion relative to the psychiatric care component by both Cummings and HMA.
Yes, sir.
I think it would probably behoove us to be able to answer a couple of questions relative to that I know are coming. One of them is relative to the capacity within the system and our patient load. I think we need to be able to dispel the myth that there is adequate capacity in Tarrant County represented by private physicians to take the entire JPS load, because that's a misnomer.
Yeah.
And people have implied that on a couple of occasions now, and I've said no, that's not accurate. So to be able to say, if we wanted to really do a true comparison of the demand relative to the JPS capacity, the overflow surplus that results from our ability to contract out is still inadequate relative to the number of patients that have to be treated. And I think we're going to have to be able to illustrate that. I think the second component becomes, to the extent that additional space and capital is needed to treat even the portion of the patient load that we treat today, given that expansion, that dollar amount is probably still cheaper than what it would cost us to have to contract that out to the private sector relative to charges that would be expected by the private sector, because the private sector is not going to do it for what we do it for, obviously. So I think just a little bit of financial homework. I think that, and Scott and I were talking about this earlier, I think Blue Ribbon is going to have some detail relative to that true cost-benefit ratio, because I think what tends to happen is people start displacing the capital obligations relative to JPS with the notion that the private sector has the capacity to go fill that need, both cost and personnel-wise. And in both cases, I think that answer's no.
And just in the last 2 months, there have been 4 times where every adult bed in Tarrant County was full, and they literally had nowhere to go.
Yeah, I think that's something we're going to have to
Yeah.
sort of articulate financially, because I think there may be some questions that come up on Blue Ribbon relative to the bond campaign that help us dispel that notion.
And I think your argument not only deals with behavioral health, it deals with primary care and the effectiveness of primary care.
It does.
And the argument to the taxpayer
Yeah.
is, how efficiently do you want to spend the money, and how can we at JPS do that? Because as you said, if you compare our price with others,
Right.
and it's not to say anything derogatory to others, it's the facts of the numbers, that the more efficient way to deal with that from a primary care and a behavioral care standpoint is this facility.
Yeah, what I always hear is that we expand our capacity, and lo and behold, it all fills up. The other side of that question of, well, we need more capacity is there if we were to double our capacity, would we fill up? I think that we will. There's no end of demand when you lower the cost. And so that has to be dealt with too. We can't simply say, well, there's more of a demand than we have, so we expand capacity, and then be surprised when that happens. And so you have to, at some point, I'm not arguing that we get rid of it at all. I'm not saying that, right? But we can't just simply say there's more demand here, therefore we need more capacity. We have to say what is the best use of the tax dollar.
I think that's fair.
It's a hard question.
Well, and I think then the third part of that equation is the best use of the tax dollar, and then you start looking at what you're doing in the institution of jail and how you deal with that, particularly with the behavioral health issue. And I think it's incumbent upon us to let the taxpayers know exactly what that dollar means, whether you spend it here, whether you spend it here, or whether you don't expand, or whether you expand, to your point, 2 times what that means. What if you expand 3 times? What is the impact potentially to inmate population, and what do we do there, and how that, so I think you and Trent are both saying the same thing. And I think it's the analytical nature of the dollar, and let taxpayers decide how they most efficiently want that dollar being spent. The one thing that we know is a constant is the population. It is there, so how do you address it? Whether we expand none, 2 times, or 3 times, or 10 times, and how efficient is that, and what's the best use of the dollar? So I think that's the key, because you're not going to get a reduction in population, so how do you handle the population the most efficiently?
Well, we talk about demand as though it's not elastic. The demand is elastic. If you say, I've got to wait 4 hours to meet somebody instead of 2, well, surprise, the demand goes down. Demand is there is the involuntary issues that have to be dealt with right now that are real, and those are a small subset, and that's pretty inelastic, I suspect. But as you make it easier and easier to use the system, and again, I'm not saying we should make it harder to use the system, I'm just saying that the more available the system is and the more responsive it is, the easier it is for somebody to say, I'll just go to JPS, I don't have to mess with my own insurance company or get my own insurance or worry about my own things, because I'll just go to JPS and they'll take care of it. They'll take care of me. I think that's, when we get to that point, we're displacing and encouraging people to use the taxpayers as their source of help when they shouldn't.
I think one thing that helps, I think, define that argument is the true context of the numbers, because what challenges that elasticity argument is the fact that even today, JPS is only serving 26% of the demand.
What's demand?
Well, demand as defined by the population level that is underneath the poverty, the federal poverty level. So when you look at what JPS's proportion of our patient load is for all those that fall under that federal poverty level, we're only 26%. So there's still a huge, and I'm not arguing the point, because I understand, but I think relative to the context of the population that falls within that group, we only serve this much of it, even today. So even if we doubled, and there's no intent to do that, but even if we doubled it, we still really wouldn't have a whole lot of system capacity, because it's such a small number even today. So it's an overwhelming argument, and I think from our purposes, and my only point in mentioning Blue Ribbon was, as we look at how we prioritize capital expenditures, what we don't need to find ourselves in is an argument that says all we have to do is transfer this to the private sector and the need will be met, because the need won't be met, because the need's not being met today, not by us and not by them. And it's short by a long ways. And in either of those circumstances, even if we were to close the doors and say the private sector can take over this demand, even if somehow we magically come up with 110% of Medicare as a payment to every single private position in Tarrant County, we still can't meet the demand. So it's just, there's always this argument that maybe there is a private sector solution that helps us resolve it. And I think it's always worth studying, but when you look at the numbers, it's an overwhelming set of variables that we just can't overcome no matter what. Capital-wise, you can't do it. We can have this argument later. No argument. I understand your point. Great question.
I have one more comment.
Yes, sir.
This has to do with physician staffing. If you're boarding that many people up in the emergency room, I would take it that physician staffing-wise, you had not planned for that. So will you not have to also plan for this increase that we're going to, would that be the challenge for James and Diana and company? It's my guess, we've always been short psychiatric therapists. I mean, always been short.
Right.
I don't know how many we are short, but I think we need to.
732 beds was the recommended level for 2017. I think we have 222?
We have 132.
Okay. So there's that number. So 600 more, and we're good to go for 2017.
So you got a lot of therapists you hire.
Yes, sir.
It's curious. I mean, it's an area I don't understand.
I understand. Well, and we want to enlighten you, and we want to have the discussion about it, and we want to talk about those numbers. So I think that's helpful.
I'm happy to visit
I
anytime.
may be wrong, but it was a vast.
I think it was 700 for the community, and I think the projected demand for us to meet was 354.
Yeah, so we were
54, so I think we were
1/3.
2 something away from where we should be right now,
Based on the entire.
at 132.
It's crazy.
Sharon, I apologize for opening that.
No, it's a great discussion.
I encourage everyone actually to spend some time with Wayne. I've had the opportunity to tour the facilities, and he's very knowledgeable and a very enlightening experience to see what we offer. So I encourage that to all my fellow board members.
I used to ask this question, was it a voluntary tour or?
Warrant, it was on a warrant.
It was a bum rap, it wasn't, no. I highly encourage that, so, great. All right, Sharon?
Okay. So I'm going to go ahead and skip on to the income statement for the medical center. We actually had a very positive month on the revenue side of things. The inpatient volumes as well as a positive collection rate provided us with a strong net patient service revenue number. The $2.5 million pickup in net patient service revenue. You'll notice that in the couple of lines below that for the waiver, we continue to not accrue what we had budgeted for the waiver, knowing that there will be a shortfall. We're expecting a shortfall at the end of fiscal year 17. We also expect there to be less dish money at the end of this year. So in prior months, that number had been $833,000. This month, I began accruing about $100,000 less in dish. The first half of this year, we have had a slightly better payer mix, hence the net patient service revenue being much stronger the beginning part of this year, and you can see that year to date. The other thing that's happened is after 6 months, we're able to go back and look at kind of that trend year to date and run that through some analytics. And DISH is a benefit for patients who do not pay or patients who we get paid below our cost. It's a Medicaid payment tool. And we are expecting to get less money through disproportionate share by the end of the year because we are getting more payment through commercial payers and other qualified sources. So what I don't want to do is come to the end of the year and have to make a negative entry to say, oh, by the way, surprise, because we've gotten more payment through other payment sources, we're going to receive less money in disproportionate share. So I'm anticipating that we're going to be about $600,000 less in DISH because we've gotten a better payment source other places. So you'll notice that in the next few months that we're anticipating. Now at the end of the year, when all the dust settles, we'll know more and we'll get notification from the state. We'll be able to calculate our final cost report, and we may pick up a couple of $100,000 or we may be closer to the estimate that we're accruing. But we'll know that closer to September. But I just want to kind of slow down that accrual towards the end of the year based on what we know mid-year. So the total operating revenue is $1.6 million favorable here, right in the center of the income statement. The salaries were slightly over. Again, the inpatient volume had to have staffing associated with that. The expenses, we had a negative impact in our employee health insurance and our benefits category. If you look over year-to-date, this was a pretty significant overage this month. We had several large health claims. We're self-insured. JPS pays all of our employees' health claims as they are paid. We accrue for those. But we had 6 very large claims come through this month. So that was a negative impact. Hopefully that was a one-time thing, and it negatively impacted April. So that was one of the main reasons that we had a negative month. The other was a large purchase service overage that you can see on the next line item. We were about $1 million over. There are several reasons for that. That's where some of our physician services also hit. And then we've had 3 contracts this year that we've approved here at Finance that have been outsourced. One of those is some of the lab outsourcing that we've done. The pharmacy contract with Maxor, we've decided to push some of the other lab areas that were not originally budgeted into the pharmacy contract. We hope to see some pharmaceutical savings once those get into the full contract and they get into those areas. That was a purchase service that was not budgeted, as well as Carter Blood Center. So you'll see some savings up in salaries because of that purchase service, but on that one line item, that is causing some overage. And then, so that caused total operating expenses to be over for the month.
Sharon, we're still carrying a reinsurance for catastrophic health care loss for employees, right?
We do, and that kicks in after $500,000 per
$500,000.
claim.
Okay.
And these claims did not reach that this month.
Okay.
So if you look year-to-date, and Steve and I talked about this when we were getting ready for the meeting, you can see that we are about $4 million short of budget this year. And you can look at each one of the variances, but the main variance is up here in the waiver revenue. And if you think about what's happening, when we budgeted where we were at FY15 waiver. When we closed FY16, we realized there was 10 million shortfall. So we're accruing at what we received last year, not where we budgeted for this year. So we've actually made up about 2.5 million of that actual shortfall. And we're still looking, the remaining 5 months of this year, we're still looking for those dollars to be made up. So that's what's happening year to date.
So what the legislature finally do this year? What are we expecting now next year after they're finished? Do we know what the reduction in UC and DSRIP may be for next year yet?
For DY 7 and 8?
Uh-huh.
That has not been tied down yet.
Okay. It's less, I understand, from what we've read. Yeah, it's gone down again.
Yes. It's never more.
No.
Hopefully it'll remain relatively the same, but it's not been, it's not settled.
We won't know that solution until September, right?
Correct.
For this year,
We hope.
we hope.
Okay.
So.
Any questions for Sharon on the
Yes.
hospital?
Any questions on the medical center? I'll cover a claim on the statistics for building counters. Because of open positions, we continue to be under building counters by about 12%. And from an income statement standpoint, it's not a whole different picture from prior months. We are still about $600,000 under in net patient service revenue, about 10% under in revenue, with about 12% under in claims and activity. Salaries are slightly over, and contract labor with locums coverage continues to be over with open positions. Purchase service is slightly over. Most of that is revenue generating physician contracts and a few legal fees and consulting with some of the comp plan that we're getting ready to implement. So with the combined revenue underage with the open positions and some of the expense overages, we did miss budget for this month, and 1.7 million loss compared to a 718,000 loss. And there are plans to talk about this more in depth at the board meeting next week. So we'll be visiting more about that.
Claim.
Yeah.
Okay. Questions for Sharon on the income statement?
Okay. That is all my prepared comments on the financials. Unless anybody has any more questions.
Sharon, is our days cash on hand policy 120?
You know,
What was
you
your
think.
question? I'm sorry.
Days cash on hand
I was
policy.
thinking it was 150.
150,
But I can
okay.
go back and confirm that. We're just over 300 today, but that's right after the tax receipts.
All right. Any other questions for Sharon on the financials? Thank you, Sharon. Yeah, I'll entertain a motion to approve or to accept the report from the CFO and financials for, this is May? June, April financials. We have a motion and a second. Any further questions? All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, Sharon. All right, are we on C now? No,
B.
Oh, we're in contracts now, all right.
Yes.
So
I've got
item
the next
6B.
two. Item B is with the Tarrant County Tax Assessor Collector. This is our annual contract, which allows them to collect our ad valorem taxes on our behalf. They have agreed to once again waive the fees for tax collection for the district. This is an estimated value of about 1.8 to 2.2 million. So very generously waive the annual fee for us.
And I think, and I want to thank Ron Wright for doing that. That was his phone call to us, and I believe we're on our 4th year of doing that, and it is greatly appreciated by the hospital district taxpayers as well.
Absolutely.
Thank you, Mr. Wright. Mr. Petty, a second by Dr. Weber. Any further discussion or questions? All in favor of the motion, please say aye. Aye. Opposed? Motion passes. Great. Item C.
Item C is a managed care agreement with Three Rivers Provider Network. This is a contract that our acclaimed physicians have currently, and one of the few that will help us achieve that alignment with both a provider and a facility agreement. It includes workers' comp, auto, and group health.
Any questions for Sharon on this exciting contract?
It is exciting. Y'all have just gotten callous to managed care contracts now. They are all exciting.
Okay, I'll entertain a motion on item C.
Move approval.
Motion by Ms. DeBose, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you.
Kelly, he did not mean that. He did
I meant it-
not.
I meant it very sincerely. Thank you, Kelly.
So callous, and it was less fun.
Item 6D, Mr. Whitman. Bobby Bill.
Good morning.
Morning. Just pretty much ignores me.
This next proposed request comes to you to amend the current sound agreement. When we brought sound in, the anticipated volume was around 12 to 15 patients per physician. And for the last several months, if not coming close to a year, that volume has been well in excess of 12 to 15 patients per physician. Now, they don't see all of our admissions, but they see a majority of our admissions, because we have six teaching teams, but they cap very early. Their cap is what it is, so everything above the cap goes to sound. So they've been encouraging some of the current sound physicians to pull double duty, to work extra shifts, and that worked well for a while, but when it becomes routine versus the exception, it wears thin. So they've had to rely on locums to come in, and that's not where we want to be either. So this proposal does two things, and we're going to address that prospectively, hopefully next month. But this one will begin to compensate physicians an extra amount for coming in and working, and also provides coverage for those times they have to bring locums physicians in, which are considerably more expensive than the current physicians that we have. In addition, it provides the chief hospitalist, Dr. Assad, with an annual increase. And we don't have an estimate. We have an estimate. We don't have a cap necessarily of what that expense is, but we're going to manage that. What I'm going to bring forward next month is most likely a proposal to add additional hospitalist resources to the current pool, partially through nurse practitioners and full-time physicians. So we won't have to worry about this going forward. But today, I'm proposing that we pay them a surge fee, if you will, both for those full-time hospitalists that work here and for the times they have to call locums in. And that should not run in excess of $220,000 a year combined, and then $20,000 for Dr. Assad, the chief hospitalist, annual increase.
Awesome. You've heard the explanation. Any questions for Bill?
Yeah. Do they have a lot of vacant positions now, or are they all
No, they really
filled
don't.
now?
They have maybe two
Maybe two.
vacancies.
Okay, so the
Their
increase-
attrition rate has been small, very small.
All right.
We have one that just announced a transition from sound to acclaim that will probably not take place for another 90 days, but we're recruiting for that.
And my final question is, when you say we have the 6 resident teams and they have a cap, do you by any chance know what that cap is?
I think it's
per team?
16 patients, somewhere in there. 16 per team.
All right,
Been the same for a long time.
yeah.
Yeah, Bill,
Yes, sir.
on the 20,000 annual increase, by approving this, that automatically puts in place every year, there'll be a $20,000 increase for the, or are we talking about this year?
It would put in place a new base salary for the chief hospitalist, right? This is kind of a makeup for a year that she didn't get one. We're sharing this with Sound. Sound is putting part of that up, and we're putting the rest of it up. It's kind of a recognition and a merit for a job well done, but it does increase her base compensation.
Okay.
Right.
I need to go back and ask it. Maybe I asked it wrong. Is it for just this year, or is this?
No, it'll reestablish the base, so it'll be for every year going
Every
forward,
year
just
we
like a
know.
merit increase.
It'll
Right,
just automatic.
right.
Any other questions for Bill? All right, entertain a motion on item D.
Move approval.
Motion by Dr. Weber.
Second.
Second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item E.
The next proposal for your consideration is a cheesy pricing agreement. That's the name of the pharmaceutical company. It's an Italian pharmaceutical company. It's been around for a long time. We normally do not bring pharmaceutical contracts to this board, this committee. We spend about $40 million a year for drugs, and all of that, for the most part, is through our drug wholesaler, Morris Dixon, the GPO. This is an opportunity that we have to do a couple of things. One is to save money. It would cost us less if we contract directly with Cheesy for this particular drug. And secondly, it provides us the opportunity to, if these drugs are on back order, which we've experienced in the past, if we don't have a direct contract with the manufacturer, we don't necessarily get our place in line for those first drugs that come available. So it accomplishes two things: less cost, $80,000 less a year if we contract directly, and secondly, we have a place at the table if in fact there's a shortage of this drug, and we could be at the first of the line versus the last of the line. So it saves $240,000 over 3 years.
That's what caught my eye. Any questions for Bill on this?
You happen to know what drugs we're talking about?
Cardine, I think.
Cardine?
Like, let me,
Yes, sir.
by us going to the direct, what do you call the wholesaler, so to speak? is
Morris Dixon, right.
Cheesy, does that jeopardize us anywhere else?
No,
at
sir.
all?
No, sir, not to my knowledge. Legal certainly reviewed the contract. Corey can address that directly from a legal perspective.
I think Alan reviewed this contract. I think it gives us the option to do both, to either go through the Morris Dixon or to go directly from Cheesy.
So any drug that we would find where there's a direct savings relative to the ability to negotiate it separately would not count against us on the Dixon contract.
That's my question.
It should not. It sounds odd. It sounds odd that we would be able to achieve this kind of a price saving directly versus our drug wholesaler, but I can assure you that our drug wholesaler has saved us millions of dollars.
Right.
And that's been validated, millions of dollars. It's not as if they're not doing a good job. They are. This is just one of those one-offs, if you will.
I got it. Thank you.
Any other questions for William?
Move approval.
We have a motion by Dr. Weber.
Second.
Second by Reverend Emerson. All in favor, please say aye. Opposed? Motion passes. Thank you,
Okay.
Bill. I think you're up again.
Angie
Item
can
F.
come join me on this if you have questions about the bidding process, but this comes to you from the Planning Committee. And this is in reference to a budgeted construction contract with what is now going to be Hutcherson Construction. But it provides an area to combine the advanced practice nurse, acute care trauma surgery nurses and trauma nurse clinicians together in the old ED area, the old operating room area, which is between the pavilion and the tower. And it realizes some efficiencies that we're always looking for. Space is a premium here, and we always try to prioritize and decide, using judgment, what's the highest and best use of the space we have available. We think it's for this purpose, and we'd like to ask your consideration for approval of this construction contract to Hutcherson. So,
Any questions for
Angie
Bill
can
or
talk
Angie?
about the bid process if you'd like.
I don't have a question. I'd just like to make a statement that I really like that you provided the criteria and the decision, and would hope that when vendors are used, that this would be the standard format that we would see. It's really helpful.
Good. Thank you. Thank you. Helpful comments. All right. We have a motion by Reverend Emerson,
Second.
second by Mr. Bose. Any further questions? All in favor, please say aye.
Aye.
Opposed? Motion
Okay.
passes. Thank you, Bill.
Thank you.
Thank you, Angie. Diana.
keep Angie here with me, so if you have questions about the
It's
process.
the Angie
you can- She is, she does know this
She
best.
won on the last one. Bring her up for the next one.
Letting it ride.
Contract is coming forward. It moved from planning forward to you. This is contract for approval of construction for the Northeast Tarrant Medical Home, which we are terribly excited about. It is budgeted. It's just over $8.5 million. The reference checks were excellent. It was based on best value criteria. We would love your approval to move forward.
Heard the explanation. Any questions for these two ladies? Motion by Reverend Emerson.
Second.
Second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes.
You didn't vote no, Trent?
Be on this week's,
Go to the board meeting next.
Yes, sir. And then on the commission report after that.
Trent, you didn't vote no? Oh, this-
Roger didn't vote no either. Neither
I
one of
didn't
us
hear
voted no.
Roger.
All
He didn't.
right, just checking. Johnson, good morning.
Would you like to have Angie come up? And sit next to you?
She's our good luck charm this morning.
Thank you. I'm here to ask for your consideration and approval of a professional services agreement between Acclaimed Physician Group and the Center for Neurologic Disorders. This is our neurosurgery group. Previously, this was a TCICC contract. This would be the first time that we're moving one of these over. It would be a direct contractual relationship effective July 1st of 2017. The current First Amendment to their contract with TCICC expires June 30th, 2017. This is a 5-year agreement, which includes Chief of Neurosciences, which will fit them into the Acclaimed service line model and a neurosciences service line, a medical director for spine surgery, and a medical director of stroke and neurosurgery to support our new stroke program. It does offer 24/7 primary and backup neurosurgical call coverage. The backup call coverage and their model is required by the American College of Surgeons for Level 1 trauma designation. That's an addition from the previous contract. It also adds an additional 40 hours of advanced practice professional coverage to support the stroke program and their participation in that. Clinical ambulatory coverage, which is the same, transcranial Doppler studies, which are the same. The partial FY17 that includes a 3-month cap that is currently not budgeted in a claim. That amounts to $513,000. A portion of that is budgeted in the previous contract in the medical center.
Why the change, Dr. Johnson, from TCICC?
It was at the request of the group.
Oh, really? Does it have does it have a material financial impact on us by contracting directly versus through TICC?
I would have to consult Sharon exactly on that. I've been told no, but I want to be.
Thanks, sir.
Great. For explanation by Dr. Johnson, any questions? I'll entertain a motion on item H.
Recommend approval.
We have a motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you. Ms. Walker, item I.
Good morning, everyone. This morning, I would like to present to you and ask for your approval for an addendum to the Talent Plus contract. Currently, we have a contract with Talent Plus to do the leader assessments, well, employee assessments for onboarding new employees. What we're needing to do now is to implement an assessment for team leaders, supervisors, and leaders, since they do have a different competency. So what I would like to do and ask for your approval is to approve the amendment to the contract for us to do this work, which will result in $32,000.
So if I can clarify, there are actually two actions that we need to take. One is the exception to the competitive bidding piece, and then the actual approval of
Yes.
the amendment itself. Okay. Any questions for Pia? Or for Corey on that, actually, too?
Okay, so I don't have a question. I just want to move approval for the amendment. Is that the first thing we need to do?
Probably need to do the exemption first.
Okay, move approval for the bidding exemption.
Second.
Are these separate votes, or are these?
You can do them all at once.
Would you
As long
mind
as you
combining?
can vote.
And to approve the amendment, okay?
You concur in that second? We have a motion by Mr. Bose, a second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed, motion
Thank you.
passes. Thank you, Pia.
Part of my succession plan.
Item J, J for Jamie. Good morning, sir.
Good morning.
Morning.
We've had Greener Pastures Landscape here maintaining our landscaping throughout the district since 2012. Their contract is nearing expiration. We've issued an RFP and received 3 bids. We've been pleased with the services of Greener Pastures Landscape. I'm asking the committee to consider our recommendation of awarding this contract to Greener Pastures Landscape Incorporated and to approve this agreement for landscaping and grounds maintenance.
Okay, you've heard Jamie's explanation. Any questions?
Why?
Yes, sir.
What's the reason for the decrease? I mean, I'm surprised. That's a pretty big decrease.
Yeah, very good question. So in the previous contract, we had various flowers and beds and services that were at an à la carte price. So we were able to roll that all into a new agreement and get a better pricing.
Okay.
Yes, sir.
Jamie, we put this out to bid.
Correct, yes.
Okay. I just asked that because of some issues that we had the last time, and I just wanted to make sure.
I remember those.
Yeah.
Remember those, but I'm not going to ask.
It was during your hiatus.
He still jumps on me about it.
I got to hear that one eventually.
Okay.
All right, so you've heard the explanation. Any questions, further questions for Jamie?
Move approval.
Motion by Reverend Emerson,
Second.
second by Mr. Petty. All in favor, please say aye. All opposed, motion passes. Thank you, sir.
Thank you.
Good job, Jamie.
Rules. Item K.
Morning.
Wanda.
Okay, this morning I'm presenting the GE monitors for the emergency department. Back in March, I presented the first phase of this, which were the PACU monitors that you approved. What we are looking to do is to standardize our monitoring system for patient care throughout the ER, OR, ICU, all those critical areas, so that we're not having to take patients off one type of monitor, put them on another one. And these monitors have exceeded their current life. Back in 2015, they were originally purchased when the pavilion opened in 2008. So this is to replace the monitors in the emergency department with GE monitors.
Okay, heard Wanda's explanation. Any questions?
Move approval.
Motion by Mr. Bose, second by Dr. Weber. All in favor, please say aye.
Aye.
Opposed, motion passes. Thank you, Wanda.
The next proposal is for, again, for GE monitors, and it's the same explanation, but this is for the ICU.
This is item L, correct, for the ICU.
Move approval.
Second.
We have a motion by Mr. Bose, second by Dr. Weber. Any questions? All in favor, please say aye.
Aye.
Opposed? Motion passes. All right, item M.
Okay. This is also a multi-part proposal. This is for St. Jude heart valves. Last month, we presented Edwards Life Science heart valves, and this is to give the physicians a choice of different valves to have here on consignment, but we negotiated better pricing with different companies. So it's a 3-part, and this is the second one of those. It will be a 3-year contract, and we will have those valves available. It's important to have multiple different types of valves depending on the patient's anatomy, and that's why.
You had me at better pricing. Okay, you've heard Wanda's explanation. Any further questions? Entertain a motion on item M.
Motion to approve.
Motion by Mr. Petty,
Okay.
second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed, motion passes. Item N.
And it's the same thing. This is the third of the heart valve replacements. So this is with the Soaring Group, the same explanation.
Same magic words.
Yes.
Better pricing.
Pricing and multiple choices for physicians based on.
Better pricing
patient
and
anatomy.
better choices. Awesome.
Don't
All
worry.
right, you've heard the explanation. Entertain a motion?
So moved.
Motion by Mr. Petty,
Second.
second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Okay.
Thanks, Wanda.
Thank you, Rhonda, very much.
Good morning.
Good morning,
Morning.
Melinda. Item O.
Okay, we've got 5 of these. I'm going to start with the first one. Notice this is a renewal for our Midas Plus contract. We've had Midas Plus for over 5 years. It's used by a multitude of departments. It's used by risk and patient safety, by quality, by patient relations, by physician services. Over the last 5 years, it's the product we've also used for our core measures. So it's key for everything that we do, and a renewal.
Okay, any questions for Melinda? I entertain a motion.
Move approval.
Let me highlight, this is also one of those two-part motion, please, for the exemption for the competitive bidding and amendment itself.
Okay, move approval for the exception of bidding process and approval of the contract.
Well said. We have a motion and a second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank you. The second one is related. It is the contract renewal for the Data Vision, and Data Vision is the reporting tool associated with Midas. We didn't need it at the beginning, so when we first contracted for Midas, we didn't need that reporting tool, but once we began to use Midas 5 years ago for core measures, the tool for actually reporting the core measures once you have them is through Data Vision, and so this is just a renewal of the Data Vision contract.
One, we had to have a two-part motion for exemption for the competitive bidding and for the contract. So move from Reverend Emerson.
Second.
Second by Mr. Bose. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you. Item
Next
Q.
one's very exciting. It's new, and we have 2 people in our audience we have our business owner and our physician champion. So I'd like to introduce Dr. Niakiris, if you want to raise your hand.
Good morning.
And Medora.
Welcome to the
Our
committee.
business owner.
Thank you both.
For a new product, some of you may be aware that we do our patients sign a consent whenever they go to surgery, saying that they do understand the risks associated with that surgery. Today, we're doing that manually. We have pieces of paper. We hand them to the patient. We hope that they get signed at the right time and at a convenient time, and we hope that we don't lose that piece of paper, and they get to surgery with that piece of paper still in their hand, and that it does actually get scanned into the chart. You can see the messiness associated with that. In addition,
No room for error.
yeah, no room for error. In addition, the state requires a certain content for each one of these consents. So the request for this particular project is to buy the content from the state, so we always have the up-to-date content every single year. It is for over 3,500 procedures, so really good, strong content, and for the technology to integrate that into Epic. So the flow now would be that we know there's going to be a surgical procedure, we enter that into Epic, the patient signs it, and it gets date, time, and stamped as well, date and time stamped, which we've been missing several times. It becomes automatically, electronically part of the record, so anyone can find it anytime from any place.
They just sign an iPad kind of
Yes,
format?
exactly.
Okay.
So much more efficient and much more compliant with the content that we need to have.
Awesome. I like it. Any questions from Linda on this item? I'll entertain a motion for approval.
Move approval.
Motion by Mr. Bose.
Second.
Second by Reverend Emerson, and also I need to point out this is another exception to the competitive. Is that? Oh,
Is this an exception?
No.
No, I didn't.
nope, sorry.
It is, but it's through the GPO. It's through the
Okay.
I was just testing Corey. He passed.
And you're on top of it.
Well done, Corey, well done. All right, so item Q, we have a motion and a second. All in favor, please say aye.
Aye.
Opposed, motion passes. All right, thank you, Melinda. And item R.
Fourth
This
agenda.
is one, if we do make a motion.
It is.
requires.
Okay. All right, okay.
Go
Yes,
ahead,
this is a
please.
fourth agenda item, and it's for Kronos. Some of you may be aware, it is the system by which we all get paid. So if we don't have Kronos, nobody's going to get a check. That's really important. It also...
Careful when you say all, because there's,
All of us are here.
Well, for me.
Otherwise, you want to know where your checks are, right?
fill out,
So we have 600, over 600 people using the system every day. It does include our time clock, so it is how all of our timed people actually clock in and clock out. It is how we submit our PTO time, how we submit our FMLA time. So, and it's how all of our nurses actually schedule the nursing time. So probably, Dorothy, that probably looks familiar to you, does it not? We've had it for quite some time. And it's a renewal.
Okay.
Okay, we have the explanation. Any questions from Linda on this item? Entertain a motion
Move approval.
with the,
Oh, I'm sorry. For the exception and for the contract.
we have a motion, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes.
I'll be happy to sign my check digitally.
Yeah, we can
Item
have-
S, Melinda.
Okay, and our last one is associated with Accenture, and it is an extension to our professional services agreement. We've had several discussions earlier this morning about Disrupt, and we have a completely new set, and I'm grateful to have wonderful Wayne here with me. We have a whole new set of measures now for our next Disrupt year, and one of our key items in being successful is understanding our baseline. At the beginning, before, we took a lot of time trying to understand what's the measure we're trying to meet, what's the baseline right now, and then what do we have to do to get from the baseline to being able to be paid. Our goal here is, as soon as we understand, starting on July 1, what those are, is to create all of the measures themselves, so we have a baseline by the end of the year, so in January 1, when it starts, we know exactly how we need to move in to make our dollars. As you can see, there is a $1 million number there, the 138 million gross for 2018 for this district project, and what we're using now is these report writers to help us generate those specific measures that we need to meet. Very complex measures.
Heard Melinda's explanation. Any further questions for her on this? I'll entertain a motion.
It's
Yes,
just
sir.
the A and B on the budgeted cost is because of implementation stages.
Yeah, I'm glad that you asked. Previously, we were using only report writing resources that were not associated with this big sudden disrupt requirement. Now we're adding some additional people in order, the requirements are very complex and there are a lot of them, adding 6 additional people for a 6-month period so that we can get them done by the end of the year.
Okay. I'll entertain a motion.
So moved.
This requires the exception. Last one for the exception.
Oh, so moved.
Second.
We have a motion by Reverend Emerson, a second by Mr. Bose. All in favor, please say aye. Opposed, motion passes.
Thank you so
Melinda.
much.
Thank you, wonderful Wayne, for all your help.
Wonderful, Wayne, good job.
That was a good job, wonderful Wayne.
Call you W squared.
Good morning.
Good morning.
I'm here today to present a amendment to a contract we previously executed approximately 18 months ago at the start of our electrophysiology program. We anticipated at that time a volume count that was based on what we had been historically sending out for service. However, our service volumes have far exceeded that, so we went back to the vendor and we got an average decrease by unit price by about 18%. So this is an amendment that gives us actually better pricing than what we had paid for the first 18 months. So I'm asking for approval today.
And you used the magic words in the middle of your presentation.
I've learned.
I love it.
Almost 10 years, you've been on there, how many? Have you ever seen Kathleen come up here with a contract that didn't decrease cost?
No, I never have.
Never,
Never
not
have.
one time.
She's my
It's
favorite.
amazing. It's absolutely astounding how she does that.
Opportunities.
We love you. Thank you so much for the work
Yeah,
you
wait,
do.
wait till it does not happen one day, and what a, yeah.
What turnout you like that?
They have put you on such a pedestal that is not a good place to be.
Somebody else present them.
Just bring Angie up. Bring Angie up here on those, yeah. Or Wonderful Wayne.
Yeah, he's got some capital. so.
Wonderful Wayne.
All right, you've heard the explanation from Kathleen. Any questions, further questions?
So moved.
We have a motion by Mr. Petty, a second from Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you. Item 7, anything legal report from council?
Just on the contracts under 200. On the contracts under 200 report, I think that was posted to the portal, there were 23 contracts for the month of April.
Other matters? Nothing in closed session.
I'm not certain if we have anything closed.
Closed. Sharon, do we have?
Yeah, we do. We do
Okay.
have one item.
All right,
in
we
closed.
will reconvene in executive session after a 2-minute break.
Not 3, not 4, 2 minutes.
kid.
Oh, okay. All right.
Okay, well, I'll call you this evening. I'm getting the evil eye from the boss. All right. See you. Love you.
All right. Good afternoon. I'd like to call to order the HR committee. We do not have any citizens wishing to address the committee, so our next item on the agenda is approval of the minutes. Are there any questions or corrections to the minutes? Okay. And can I get a motion to approve the minutes? Okay. Motion by Chuck, second by DT. All those in favor signify by saying aye. It's not on the agenda, but I first would like for Mr. Early to have a brief report.
Thank you, Madam Chair. I wanted to let you all know that when we were announced one of the top 150 places in the nation to work by Modern Healthcare, that complimented 6,500 employees, and that complimented you all as a board. The work that you all did to allow us to become one of the best places in the nation to work is powerful. And I want to personally thank you all as board members for your guidance, your structure, and your direction that you've provided us, because becoming Modern Healthcare's best places to work is not an easy task. It's not an easy accolade that you get. I want to thank Pia and her team, and I want to thank Nikki previous to that, because the combination of Nikki and Pia in creating an HR department that has been significantly beneficial to this organization, the team that I get to work with, and y'all as board members has made a huge difference. So I want to thank y'all. That's something for all of us to be proud of, and I think it's quite an attribute. And I know that so far Pia has told me that it has been the first line of everybody that is coming here. That seemed to be the first line everybody says, you do know that we're now Modern Healthcare Best Places to Work. Thank you for interviewing with JPS. So I think that's wonderful. So thank you, Madam Chair. I wanted to thank you all.
All right, thank you. Next, Pio, you want to come up since you are kind of on the item for the next 3 or 4 agenda items? Okay.
Okay, good afternoon, everyone. Thank you to the HR committee for allowing for me to present on the human resources key performance factors. When we last met in the March HR committee, we received feedback on a best practice and to a way to deliver the HR metrics. So what we have today is a redesign of the HR metrics by job class. And of course, through job class, listed are the job families that we currently have as an organization when we're looking at different positions within the organization. So one key thing to focus on with this is benchmarking. The reason why we benchmark, because we want to ensure that we are competitive and relevant to industry standards relating to turnover, involuntary turnover, 1-year turnover, and 90-day voluntary turnover. If you look here on this piece here where it's the Saratoga benchmark, that's the Saratoga data that we benchmark against through PricewaterhouseCoopers to assist us in ensuring that as an organization that we are focusing on where our targets need to be relating to turnover. Okay. Some of the key wins when we look at the turnover data, I would like to look at nursing for a quick moment. When you look at nursing and you look at the annualized voluntary turnover, nursing is doing very well because when you bench it against the Saratoga data, they are sitting in a good place. A great focus with them is relating to the 90-day turnover, because that's a key measure that we do want to focus on with 90-day hires, ensuring that we are hiring appropriately and that we are also taking the time to orient and train our team members as well. So with the nursing team, that is a win for them because they are below the standards in the 90-day window at 4.41%. The industry standard with Saratoga is 7.3%. Another area too, when we look at it, is patient care support. One thing to make you aware of is that with the nursing team, they do have the job, family, or patient care support, and those are positions that consist of CNAs, tech positions, and they also fall into that category too as well. So they are right there at the industry standard when we look at the Saratoga data. And then we also need to do some focus with the voluntary turnover within that 1 year. But also too, that's a win for them as well because they are a mixture with the nursing job family as well. Some areas that we need to look at far as opportunities is looking at management technical and the management positions to identify, looking at through exit interviews while we are having turnover in those areas. But we know that there is more work that we need to do there in focusing on the turnover by job class. One key thing to point out with this is that the measurement period for the turnover data was October 1st, 2016 through April 30th. The data that we looked at before relating to the turnover data was by quarter. So this is from October until April 30th, 2017. Are there any questions relating to turnover? I'm sorry, can you say that again, DT?
Could you help us understand the
Yes,
chart?
sir, definitely. So let's look at nursing. So when you look at nursing, the active employees in the nursing job family, and these are all of the positions in the nursing job families to include RNs, to include clinical RNs, probably about 300 jobs that exist in the nursing job family. So the active employees, meaning they are active within the organization, is 1784. The terms within that period, October 1st, 2016 to April 30th, 2016, was a total of 136. We had 95 vacancies during that period that were open. And then when you look at annualized turnover, it's 9.99%. The annualized involuntary turnover is 3.07. Annualized total turnover for that group was 13.06. And then the 1 year turnover was 19.67, and then the 90-day is 4.41. When you're looking at all that data, and then when you look at the box at the very top, when we're looking at that data, we're benchmarking it against the Saratoga data, which is the national data that we benchmark against for healthcare HR metrics.
Yeah, what I'm trying to reconcile is the like information technology. You have 6 old terms, and then less than 1 year volunteer turnover is 31.17%. Yeah, I wasn't sure how to get that high, but the number is so low.
Say that again, I'm sorry.
If you look at that line, like information technology, and you only have 6 old termination type thing, but when you look at less than 1 year voluntary turnover, it's 31%.
Exactly. So again, this is not by quarter, it's by October 1st, 2016 through April 30th. So the data is going to look different than when we pull it from a quarterly basis. It's not quarterly data, it is from the measurement period October 1st to April 30th. So the data will look different compared to when we pull it on a quarterly basis.
But I think his question was if they had 151 active and only had 6 turnovers.
Okay.
And how did that, even doing annualized, come up to be 31%? I think that was the question.
Okay.
That might be something we need to go back and relook at that data.
Okay.
Because something.
6 months, we have had 75 people turn over in there.
Say that again?
In the 6 months before this data, correct.
I'm sorry, say that again, sir.
What's reported in actives, all terms, and vacancies is within this timeframe only.
In this measurement period, yes.
But when you look at the annualized, it is taking the entire year. So 1 year's worth of data, not the 6 months that's October through April.
Oh, okay. All right, I guess the measurement period we had was October 1 through.
1 to 4.
Okay.
Yeah, and that looks completely
That's the-
different than quarterly data.
Then, oh, okay.
Yeah, it
One more
does.
reason why it's good to have you on this committee. Yeah.
Okay, all right.
31% of the six that turned over.
Sorry, I'm sorry.
What did you say?
31% of the six that turned over, not 31% of the
Right.
151,
Exactly.
most likely.
Say that again, I'm really getting.
31% of the six.
I'm lost.
So what Sharon's stating that possibly it could be 31.17% of the six that is 31% of the 151, which got that number. But the piece that we have to think about, it goes to what was stated, is that when you look at that measurement period, it's going to look completely different compared to the quarterly data. And that's something that we have to think about as we have each HR committee going forward, because each HR committee, we're going to be looking at job class, and then we're going to be looking at quarterly turnover as well. And those numbers are going to be looking different depending upon the time when that data is presented.
Right. Because your annual is going from
It's annual, and then it's
from
quarterly.
Okay,
Yeah.
from the beginning of,
Mhm,
okay.
exactly.
Okay, all right, okay. DT, did you have another question? Okay. Well, I want to thank you for going back and answering all of the input and putting the numbers to it, because that was a question that someone had. So you did a very good job of coming back, presenting that information.
Thank you very much.
I have just one question, because when I look at management, that's the one that's working right with the staff. That's the, that's where the rubber meet the road. So are y'all doing anything special on that one? Because that one is high to me. I mean, because if you're having a lot of turnover with that team, that says that those are the ones that's working with your employees, and so that's kind of high.
Yeah, and I think that question will be answered when we go later to discussing succession planning, because with the succession planning, that's going to show the scope of work that we would need to do to attract and retain leaders within the organization. So I think that will assist you with that question and see the
Okay.
work that needs to be done related to that.
What level does that start?
Managers are manager.
Under management.
Yeah, manager is manager, director, and executive director. Yes.
Yeah.
So it doesn't go all the way to VP?
No, it does not. Executives have a different job family.
The
Yes.
executive is up top.
They do.
Well, I guess the other question is, look like that's on the 90-day turnover. That was one that's 7 point, well, I guess that was a little bit less than okay. I looked at that backwards. Okay.
And then the Saratoga benchmark.
Yeah, okay.
I think what surprised me is I was expecting the 90-day voluntary turnover to be higher, and then as they go out, it's less, but it's actually the reverse here.
Say that again, DT?
The 1 year voluntary turnover is a lot higher than less than 90 days. I was expecting the 90 days to be higher, and then when they go past 90 days, it's slowed down.
DT, can he repeat what
I
you
think
said?
his question
Okay.
is that people, he is surprised that more people are not leaving within the first 90 days, but more people are leaving within the first year. And his comment would be, you would think if you got here and you didn't like it, you would see it, or you didn't like the circumstances, you would know within 90 days that they're staying and then leaving on an involuntary basis later.
I know for nursing at 6 months of experience here, other hospitals was recognizing that as a year and a half experience, and they were getting an increase. So nursing was losing, we were losing a lot of nurses at 6 months, because the other hospitals would recognize that 6 months of experience here at their hospital would equate out to over a year. So they would get an increase. So we had to work at setting up something to give them an increase at 6 months so we could reduce that. So I just know that for nursing, I don't know about any other group.
But also keep in mind as well is that for that 1 year, that's the honeymoon phase for all employees. What occurs is in that 90-day probationary period, that's a time when feedback is provided to the employee. And after 90 days, they could feel that they are a good fit for the organization. That can occur. Then what happens once that 1 year comes around, that's at a time of where they're really thinking about, is this the right position for me? Does the leader feel that this is the right fit? So many things can occur during that actual 90-day to 1 year period that can be considered for those individuals.
All right. Any other questions? Thank
Okay.
you.
Thank you.
Before we move on, this will be our dashboard unless someone
Bless you.
else has some comments or wants something else added, but we're pretty happy with it, right? I know Tia and I talked about looking at a couple of more things to look at is our recruitment costs and some things, but we'll bring that back, okay? All right.
Okay.
Second item?
Yes, second item on the list is the Human Resources Dashboard relating to employee dispute resolution process. And just to explain about the employee dispute resolution process, this is a time where we have employees within the organization who can go through the dispute resolution relating to if they receive a written counseling, final, or end of employment. There are two processes that they can go through relating to this process. They can utilize a panel, which consists of their peers, and when I say peers, individuals that are in equivalent positions, and then also leaders that are on the panel. And it consists of 6 individuals, and they have a choice to pick those 6 individuals to be on the panel. The second process that they can utilize is going to an executive and presenting their case to the executive on why they feel as though they should have not received that written, final, or end of employment. The purpose for this dashboard is to show you relating to employees about the process, about dispute resolution, to ensure that they understand the process and that they understand that they have, I would say, the right or they can participate in this process. So looking at this data here, it shows you the top reasons for why we have individuals that depart from the organization. As you can see, those are relating to work performance, policy violation, and attendance as well. We pulled the data from 2014 through 2016, and the dispute resolution process that we currently utilize within the organization, we started this process in 2013. So we have the data for the last 3 years showing the individuals that took their ability to participate. Now, when we present this information to employees relating to dispute resolution, they are not required to participate. It is their choice. We do not make them do this. So I just wanted to put that out there just so that you can have a clear understanding that it is their right and their choice to participate in dispute resolution. When you look at the numbers from 14 through 2016, it shows you the number of individuals that did participate in dispute resolution. Of those numbers that participated for those years, for 2014, we had 5 dispute resolutions that were overturned. For 2015, there were 10, and then for 2016, there were 11. So it shows you that this is a good faith effort from the organization, showing that this is a great process for employees to utilize if they do want to participate, and their voice is heard when they go through this process. So wanted to show this information to let you know, again, this is relating to written counselings, final counselings, and then also end of employment, and that we utilize this, I would say, very heavily in the organization to make employees aware of what they can do when they feel as though that they should not have been counseled for their performance or any other indications as well. Are there any questions?
So
Yes.
half of them go to dispute now?
Half of them? Well, again, when we look at the numbers, and when we look at 2016, the number of dispute resolutions that were held were 673. But again, looking at the number of terminations, again, all of these dispute resolutions consist of written, final, and end of employment. So it's a bigger criteria than just involuntary turnover.
So when we are looking at the numbers of involuntary terminations is not a key indication. You're saying this is involuntary but all involuntary terminations do not request it.
They do not.
And it is not just involuntary if I have a write-up and I want to dispute that, so of that, 73 folks decided that whatever happened, I want someone to review it.
Right.
And so of that 73, 11 of those were reversed or turned over in some type of way.
They were.
Okay, about 10, a little over 10%. Oh, she gave us the number. It's not up there. She just voluntarily had that information. If we present it again, we'll have it on there with some percentages, so. Okay.
Yes, sir.
Okay, let me just, I'll deal with 2016 for a second.
Okay.
The 73 dispute, let me back up. Give me some examples of a dispute that a person would file that would go through a dispute regulation, resolution.
So, for example, what can occur is if someone is, they receive a written for attendance, they can go through dispute resolution. If someone is terminated for performance or attendance, they can go through dispute resolution. So it's anything in that criteria, we open that door to allow for their voice to be heard on if they feel as though that they should not have received that counseling, or do we need to reverse it? So when you think about us as an organization, when we receive DFW Top 100 Workplaces, when we just received Modern Healthcare Best Places to Work, these are the practices that you have in the organization for the employee's voice to be heard, to show that we, out of good faith, listen to our employees. And it's evident through that when we look at 2016, where we had 11 reversals relating to dispute resolutions, and that speaks very highly. And that could be, when we say dispute resolutions, it could be the panel overturning, or it could be an executive that heard that employee side that's overturning that resolution as well.
The reason I asked that, because I just want to make sure that employees didn't feel they could go just because you're my supervisor and we just don't get along, This really is performance-based, that's substantiated by written
counseling. Yeah, and also too, with that process, what can occur is that step one of that process, they can go to their leader and have discussion with their leader to discuss reversal of that. So that's where we open that door for two-way communication to occur, for them to have that discussion. If they feel they do not receive resolution from there, what can occur? They can move forward with the panels.
My other question is I don't know if we've looked at this. When you look at 2014, I'm at the involuntary termination for a second. 144, then 173, then 163. Our organization grew also. So I just want to say that they may not want to be careful that we say, wow, it's 173 involuntary terminate, but if you equate the number of employees we had at that time versus the number that were terminated.
Right. It's a small percentage.
Yeah, because, you say 163 in 2016, but we made it, 1,000 employees more in 2016.
Right.
So.
That's a good point.
This may be out of line here, but I think in 2015, the whole time I was on the board, only take one case of wrongful termination. And the whole time I was here, I only take one case of wrongful termination on medical condition, and it went to dispute and it got reversed. But the thing is that that employee actually was moved to the night shift. Make it it's almost borderline retribution. And I think there's some room that we may want to take a look at to follow up. I don't want to bring it up. I think it's done. It's a long time ago. But I just want to make sure that we probably not counsel the middle management correctly. But that's only one case I was involved, and I know that he was moved to late shift at night as a penalty. And but I think part of the improvement, maybe we take a look at some of these, if it's reversed, to see anything we can help. I'm not talking about penalizing anybody, but just as part of ongoing improvement here.
That employee worked in the radiology and MRI machine.
And I actually counsel him not to seek legal help. His daughter actually is a reporter, and she does have a microphone and a TV, but we calmed that one down.
Let's talk about an elephant in the room, because I have no problems talking about this, and that is, when you have performance issues of any type, there is a criticism, probably of this organization because of its size, and probably any organization, that if I speak up, there's going to be retribution. So I'm afraid to speak up. We want to be real sensitive to that, and we want to try to address it. And we want to try to address it in two ways. What is legitimate, and has retribution been involved in it, or is that what somebody says to make sure that they can keep their position and nobody says anything about them? You think about human nature. If I tell Alan Podowitz that I'm really mad at you, and I'm going to go to the newspaper, and I'm going to go to board members, and I'm frustrated with that, there may be the potential that he as a leader is not then going to look at something that employee has done or not done. It's human nature. Say, you know what, I don't know that I want to fight this battle. I don't know if I want this employee going to the board or going to the governor of Texas, or not just in healthcare, not just our organization. So you may have a tendency to say, I'm not going to deal with that employee, and you may retain a lower performer or challenges with that performance based on that. Or you may be, and I'm not going to use you as an example, we're going to use Sam Jones, who doesn't work here, who is a form of retribution, and I'm going to get you, and you're never going to talk again. It's trying to balance that between employees that use it as an unfair tool to stymie an organization, and leaders that could be punitive in a poor way. But we try really hard to figure out how to deal with that, and it is an ongoing issue, whether you are a 6,000-person employee healthcare organization or you work for American Airlines. It doesn't make any difference, and that's what we're trying to do. The other thing I will tell you is that when you board members hear from folks, or I, as a CEO, hear from folks, one needs to always still put that in perspective. Because let me assure you that if I, as a CEO, get 5 people in my office complaining about something, you can draw the conclusion with 5 people meeting with you that it's epidemic. But you've got 6,000 other folks that seem to be doing quite well. You have to put all of that in perspective.
That was the reason why I said I only take one case, and I have to meet with him in person to see eye to eye to make sure that he's not lying to me.
Sure. And it's hard.
For the most part, I mean, 99% of the time, I just discount them. Because I don't think it happened here. It's just that one particular case a few years ago. But that was a very isolated incident.
I think to a large extent, we constantly keep our guard up in the best that we can to try to figure out those issues, where we're being fair, where we may not be being fair, and then trying to make sure that you have a workplace that people want to join, and you have the performance that the taxpayers and you as a board expect. And there's a lot of plates on the end of sticks that one has to balance in that. But I assure you, at least from my standpoint, I and that executive team tries to do it very hard, but if you see problems one way or the other, we'll definitely review them any way we can.
I think you may misunderstood what I said.
No, I didn't misunderstand your point. I was just addressing
I think
another issue
for the
as well.
most part, they did it right. Just sometimes you have young managers that don't understand
Sure.
inclusion. So that's why I said maybe a follow-up may help.
I agree.
That's all I'm saying.
No, I totally agree, and we do have that with some of our younger leaders, and sometimes we get in the situation, because we deal with humans, is when you are promoted, you act differently than the person you were before you were promoted. Sometimes people accept promotions in different ways. Some people take them in their stride, and some people think that it is the keys to a kingdom. So we try really hard to balance the human aspect.
I mean, you guys done a wonderful job since I've been here. That's why I was very sensitive when I say.
No problem.
Just a quick follow-up on that may help.
Okay, thanks. So we'll look at that. Any other questions on that? Well, thank you for bringing, that policy was put in place, I think, right after we started this committee. All right, and so I just kind of wanted to ask for a little follow-up on it. And it's a good policy, so. Next is our market assessment update.
Yes. So with our market assessment update, I wanted to bring to your attention relating to market assessments that we do on a continuous basis to ensure that we can maintain a competitive workforce. As you can see, what is listed, in 2015, we did patient care support, police and support services, and the funding for that was $2.2 million. 2016, we looked at nursing, patient care support, which were additional positions, and police and support services, which was 2.2, and we also included residents in this, and this is funded from the operational budget for residents. Currently, for our team, we are currently in the process of doing the accounting and finance, HR, IT, office support, and professional services, and this will result in $1.8 million for us to be able to apply increases to these employees. Now, one factor that we do look at when we are doing market assessments, this is not a cost of living raise. This is a time of where we look at market data. We have 3 forms of market data that we do look at to ensure that within the healthcare industry, locally, regionally, and nationally, that we have competitive salaries. So at that time, that's when we make the recommendations on what the grade changes will need to be for those jobs. We make those appropriate changes and then apply increases to those applicable employees for increases. So we're looking to roll out the next market assessment. We're looking at mid to late June to make leaders aware of when that assessment will be paid out to employees. Then again, what we will do in 2018, we will start back over again with nursing, which will result in $3 million, and then also with the management and technical group, which will be $2.5 million. So for us, this will be an ongoing process that we would do on an annual basis to look at job families, to look at salaries, to ensure that we can attract, retain, and stay competitive within our industry.
The dollar figures, do those represent the amount of money to bring the particular levels up to par, or the cost to do the assessment?
The cost to bring the individuals up to par.
So where did those numbers come from?
Those numbers came from when we run the data and we do the market assessment. We look at the numbers, and that's the funding amount that would need to be done to pay out for those job families.
I think, Roger, we have a company that come in and look at all of the job categories for staff, the same way we do for the executive, and that will be coming to the committee. The first time they brought that to the committee, it was huge, and so we did it in, we couldn't do it in one cycle, so this was a part of that overall plan. When we first looked at it, we had many, many job categories, so they narrowed that down, and then they looked at where were we in various categories. So they came back with a proposal that says for us to catch up and maintain. This was what they were recommended. But it is time for that group, that survey to come back, the data to come back to us for staff. So they should be looking at that.
My only curiosity is how do they know that we need $3 million for nursing in 2018?
Because what occurs is that when we look at industry and when we look at what other healthcare organizations are paying, they run the analysis, provide the input back to us. And this also includes an inflated rate because we know that the industry is going to change once we get to that time of doing the market data.
I'm lost. I still don't know what the millions mean.
Okay. The millions mean for us that, so say for example, with nursing, whenever we do the nursing job family, that affects close to probably about 2,700 employees. Okay, so when we're looking at these 2,700 employees, we're looking at the market data to ensure that we can stay competitive. And what we apply is at that time, based upon their years of service that they have provided to the organization, we provide a percentage amount to those individuals. And once we do that to that 2,700 or 3,000 employees, that's going to equate to us paying out that $3 million to bring those individuals up to the appropriate salary range for their current roles.
I'm still a little lost.
Can I give an example?
Yes, sir, you can.
So if we're paying $50,000 a year for a nurse here, and Baylor is paying $55,000 a year, then we may lose nurses to go to Baylor for $5,000 a year. But what we're doing is a market analysis that's saying not just Baylor, but All Saints, and Plaza, and Hughley, they're all paying $55,000 to $60,000 a year, which means that we're a great place to get training, but we're not a great place to stay. And so what this does is we need to balance back out to the market trend. And so it's that difference between 50,000 and 55,000 that accumulates to the 3 million when you have the 2,700 people. We have that with our techs. We pay $30,000 a year for our techs. They can go work down at Springwood for $40,000. And so guess what? For them, it's easy for them to leave because they can make $10,000 a year more, even though I think we're better people, provide better care.
So it would be the market difference times the number of employees in that category that would come up for the 2015, for example, would make the 2.2 million.
Yes, sir.
Yes, sir.
And that was identified in our market analysis as the critical positions. They always project that, and they said, you're going to have some positions that are going to move faster than others. And so nursing and that technical one is one that they always point out in the
I
survey.
understand that point. How do you get to what Roger said, how do you get to the 3 million for 2018, which is not even here yet?
Because we have already done an analysis. We've done the work already. The work is sitting there. So when we have done that work, what we have to do, we have to analyze all the positions. We go out to the market, and this is by us using market data. When we have looked at that market data, the market data communicates to us where our job codes need to sit. Those job codes, they all have assigned salary ranges. Is either do we keep that job code as is, or do we move that job code to a new salary range? With that, once we look at that data, when you look at all the employees that we may need to adjust appropriately, going by the example of where an employee may make $50,000, they get a job offer for $1 more. Well, for us within JPS, what our goal is to maintain our current employees. So what we are doing, we adjust those individuals appropriately to make sure that they're making the appropriate salary, which is competitive with the industry. That's how we get to that.
We're looking at industry trends, and we're looking at where the market is going. That market change for 2018 could be significant if Baylor says, oops, we're going up $4 an hour. increase. That number's going to change. That's based on projected numbers that we can see. Just like if you invest in the stock market, if your stocks stay the same, this is where we think you're going to go by the year 2019. The other factor that's not in here is the amount of loss that an organization takes when you retrain and you lose somebody.
Well, that was actually one of my next questions, was what happens? Is that built into that 3 million at all?
That number is not built in, the retraining and the retooling and all, because we can try to do that and try to look at the cost of losing an employee, extrapolate that over the number of employees that were lost and what it would take to retain them and keep them. The other factor that is important with these numbers is this is not going from an airport hub to making a decision as to whether you live in Dallas or Atlanta and going to that hub. This is so tricky for us because you have a concentrated workforce in a concentrated area, and you turn down Rosedale and you take a right or a left.
I understand.
So that's why these numbers are so important.
Yeah, because I kind of said what Roger has said, in this public sector, is that even though you see the 3 million or the 2.5 million, that's good for HR and Sharon to look at and have an idea, but you're not guaranteed it's going to hit that number. I mean, because you look at the inflation cost at the same time, and then when they compare the study, but it is a good number to gauge on where we're going to be headed. But that number is not sunken cement. But it's a good gauge to know where you're going to go.
This is on top of the yearly salary increase.
Yes, sir.
Yes,
It is.
right.
It is.
Continual in perpetuity for those job codes. My question is so in 2018, are we going to budget additional $5.5 million in the budget to cover this stuff?
That's what we're asking for.
Sharon has a lot of money over there.
That's what we're asking for.
Okay.
Yeah, that's what we're asking
A lot
for.
of money.
It may be a little bit higher too, because if it's as hard as when we convert Epic and all the IT people go up, with all the patient center, medical home, background, all that stuff kicks in, you reach out, those people now
Right.
working part-time behind the phone, they can make a lot more money, so we have to be very competitive also as well.
And one thing I think is a plus that this is taking place because the award that JPS got about the top 100 employees know that we are looking at them and, considering looking long range to try to retain them. I think that's a plus.
Well, I just think that the committee started looking at our compensation program and plan, when we first started, and came up with a philosophy, and then based on those market surveys and analysis, we've tried to maintain that. The same way, we don't bring the staff market data to this committee. You normally just see the executive. But, when I don't have anything to plug in, I'll bring it in so we can go through it. But it's a wonderful report to look at. When we first started, we had to look at it to get a better understanding of how they was doing that. So I can look at bringing that when we bring this data back. Any other questions on it? All right. Next on the agenda is, HR committee assessment. Okay. I was getting excited. I thought I got to my other one. We are almost there. Yes, we are almost there, I promise you.
So the next agenda item is the Board of Managers Human Resources Committee Assessment. It is that time of year for this to be provided and to receive your input on the assessment. Purpose for presenting this to you today is just to get your approval that you are okay with this template to be sent out. If you are okay with the template to be sent out, to receive your input. What will occur from here, Elva will send this out to the board committees, and input would be sent back to Elva to generate that data. Is there
This
anything?
is just looking at how effective this HR committee has follow through on what our charges are. And so Robert and Bill and Sharon have input on us too.
If you would like for them to, yes.
All right, okay, I'm okay with it.
And we're going to compare that to national averages, and we're going to compare this committee to benchmarks.
All right, I'm open to it. Okay. Did anyone have any questions on it? Because we are required to do it annually on us. We're a little slow, but we'll get it done this year.
Do we need a formal motion?
Do I need a formal motion on this? No.
I don't think so. But when we need one, we're going to go to you. You're the man.
So, but what we will do is send them out to the board now.
Yes, we will send
And to
out.
the different groups, and then we'll get a summary report back. Okay,
Exactly.
all right.
And we'll present it in the next HR committee.
All right.
Okay.
Okay, succession planning update.
Let me begin by telling y'all, and we appreciate your being euphoric about it. Here's the situation that we have found, and I've read a few articles about this. Healthcare in particular, as an industry, has not done succession planning. We are not an organization. When DT first came on the board, one of the first things he gave me was a succession plan for another organization. It is most uncommon for organizations in healthcare to have succession planning. But I think when you look at best practices and you look at an organization that is evolving to be a better organization, succession planning is a critical element. The approach that we've taken with Exeter, which I'm proud of, is there's a variety. I can't find any literature on the best succession plan. You can find one that says this succession plan worked really well at company X or company Y, or this, but industries are different and the approaches to succession planning are different. What I'm impressed with our work with Exeter and talking to a few of my colleagues in the industry is what we have tried to put in front of y'all today is a succession, and if you asked 10 people to look at 10 succession plans, they would see 10 succession plans. There is not, one is one. One of the things that we wanted to put together is how do you put the best pool of people inside your organization to be able to successfully move up in that organization. Whatever level you are, if you're at level Y, how do you move up to level T? If you're at level T, how do you move up to level D? How does that happen? How do you move through the organization? This is not a plan that says if so-and-so leaves their position, then so-and-so moves into that position. This is not a succession plan for the presidency of the United States and the United States Congress. That's not the way this works. And it wouldn't be good. You would be so divisive if I said, okay, if so-and-so leaves, then Joe Smith is going to move in or Jane Smith is going to move in. The divisiveness within your organization to select your children in that manner would be horrible. So what we want to try to figure out is how to put a plan together that you as a board and we as an administration know that we have the best pool of people to quickly move up in whatever position changes happen. And so I'm proud of the work that PIA has done. I'm proud of the work that Exeter has done. And PIA is going to introduce the Exeter team. I think most of y'all have met them and seen them and worked with them before because we've used them quite a bit. But I just wanted to let y'all know that this is a step in the right direction for a best performing organization. It is not a step that most of our colleagues in the healthcare industry have truly addressed.
Okay. Well, thank you very much, Robert. Before we do move forward with the presentation, as you all see sitting behind me, we have Audra and we have Lauren, who was part of this great project for the organization, and they were dedicated in assisting us in moving forward for us to be able to produce this and present this to the HR committee. For myself, I ditto Robert's words. This was a great project for us to do to assist us with the organization, with our leadership. When we think about our leadership team, they are the core to our people. With leaders, It's imperative that they are developed, it's imperative that they are competent in their roles, and it's imperative that we have plans put together for these individuals to be successful to the organization. With this succession plan, it was intentional, and the reason why it was intentional for us is to ensure that with our leaders that they have the appropriate tools to be successful in their roles. We want to ensure that they are engaged, because when we look at engagement, what is the key factor to engagement? When we have high engagement, we have high patient satisfaction. So the core to that is making sure that we do have leaders that are developed well, that leaders that understand their roles, and leaders that have the ability to develop others as well. So let's get into the presentation here to talk about the project overview. The project overview existed with the assessment for the first phase of us consisting of the 9-box assessment. The 9-box assessment was completed by our executive teams along with their leaders if they had to assess another leader to be able to provide feedback on where their leaders were competent and had the ability to perform appropriately in their role. When we come back to the committee in September, what we will do, we will have additional work to show a 360 assessment and then also a leadership assessment as well, so that we can identify those top performers. Your top performers, as we go through this presentation, you will see that they are your star performers. And with the star performers, the work that we want to do around them is to engage them on how are they star performers? What is the work that they're doing to be successful within the organization? When we look at phase 3, individual development plans, they are a plus, they are a positive, and that's a way for two-way communication for the leader and another leader to be able to converse about what do we need to do to make you a high-performing leader, what is the stretch goals, what are the assignments that need to be given for you to be competent in your role, and then also for you to grow within JPS. And then next from there, we will conduct quarterly updates once those individual development plans are given to discuss to make sure that we're following through. And so that when we do come back to the committee to present additional data, we can show where the movement is occurring within the organization. So here's a snapshot of the leaders that were assessed. 261 leaders were assessed. 73 were retained from this assessment because they had less than 1 year of experience. So overall, there were 188 individuals included in this assessment. When we look at those 188 individuals, they had 3.67 years of experience relating to their management role, not their time with JPS, but within the management position. Also, there are some demographics that are listed here. As you can see, when we look at gender, females, it was 126 out of that 188, which is 67%. And then looking at males is 33% and 62 out of the 188. We also included race and ethnicity with that, looking at the non-minorities and then also the minorities and then also the age groups as well. Are there any questions on this slide?
Do you think, when you look at the gender, that is also the norm throughout the industry?
In healthcare? Mm-hmm. Yes. Mm-hmm. That's normal in healthcare.
So we guys are scared to go into healthcare? Huh?
Yeah, I guess, yeah. No, what that tells us, the story with that is that for us, when we see that, it's focusing on how do we attract individuals that are less represented in your organization. That goes to your recruitment efforts. What does that look like? For us, we're building a affirmative action plan, and where we're less represented, that shows that with our recruitment efforts, we need to target colleges, programs to be able to utilize and represent us in that organization. So to answer that question, that's the best way to look at that. And we have to put a strategy around that piece as well. Any other questions? Okay. So here what we have is a 9-box summary. The 9-box summary basically consists of leaders, their performance, and their potential. When you look at the 9-box, if you look at the very bottom here where you see potential, this shows us where leaders have the potential to perform in their positions. And then here on your left side, you see their performance. So you can have someone that is exceeds expectations, but they may not have the ability to move into another position for another 2 to 5 years. Number one, with that potential piece of it, it's truly the impact that a leader has to JPS. Are they strategic? Do they have the ability to have employees follow them? Do they have the appropriate communication skills to be able to converse with employees in crucial conversation? So when we look at their potential, it's the impact that they have to the organization, to assist the organization in moving forward. Here, when you're looking at the superstar, we have 13 employees there that are superstars. What our strategy with that is, how do we get our other employees to that superstar range? What is the work that needs to be done? What has that experience been like for you to be considered as a superstar employee? Okay. Questions relating to the slide?
Determine a superstar.
A superstar is a person that is strategic. They have exemplary performance reviews. They have the ability to accept stretch assignments. You can expand them in their role, and they have to have minimum supervision when it comes to special projects. That's a superstar.
How does one get to be a superstar? I mean, your boss says,
Well, you're going to go through a process, a series of things. There's not one answer to that. First of all, if I'm supervising Dorothy Dubose and she comes in for her annual evaluation, then she's going to get good marks on that. I've looked at her 90-day planning. She's gotten good marks on that. She has done a variety of things above and beyond the call, so that some of it's going to be empirical and some of it's going to actually be structured on my reviews of her, and some of it's going to be the comments that we obviously get from her coworkers and what she's doing on committees and how involved she is. So there's a variety of factors. Some actually have numbers and some are just subjective that we're going to review.
Mm-hmm.
You're on the superstar list, so it's okay.
Let's just say you're on a list.
Any other questions on that slide?
Thank you, Dorothy.
Yeah.
A good example of that would be, for me, is, I forget what we call that, the program where you give the employees the awards.
Yes, the Excellence Awards.
The Excellence Award. And that employee gets it this year, but you see that same employee at that same level after they get the reward, that would terminate them a superstar, basically.
Yeah, Golden Stethoscope Awards, right? A variety of awards that are selected by their peers.
Right.
It's not just a supervisor, it's peer awards, those type things. All are factors, all come to a culmination.
Yes. And then also here, when you look at the rising star, these are your high potentials.
Not the church, those are people.
I'm losing this committee. Any other questions on that one? All right.
So when we look at the 9-box summary with demographics, this is very valuable for us to see the data that is there. When we look at the data, more than 90% of the JPS leaders, they either meet or exceed. With that, what we're saying is that with the 90%, we have individuals that we truly need to focus on and identify ways to be able to move them into the other categories. So when we look at the core contributors, that is a category there that is well represented for minorities and then non-minorities, and also under the age of 40. But with that, what we need to show is that how do we get individuals prepared to move to other roles within the organization, and then also out of their comfort level to be able to perform. That will be a study that will be done through the individual development plans. And when we look at the IDPs, which is their individual development plan, no two employees' individual development plans should look the same. So what that strategy will be is once we develop, that's how we will know how we will be able to move those individuals to the next level to be prepared for the next level position. Questions? Okay. So looking at the next slide and look at the question, when will this leader be ready to move into a different role? So when we look at this slide, the story that it is communicating to us and the story that it is telling us is that we have 102 employees out of the 188 that are well-placed. So when we look at well-placed, that means that for these individuals, they do not want to move to another position. They're comfortable in their roles. But what we have to do, we have to be able to provide, I would say, an IDP for these individuals to grow and develop so that they can be able to assist us with benchmarking and leadership for the organization. With that, when you look at the industry standards, that is a very high number for us to have when we look at employees that are in the well-placed, no more moves. So we have to focus on putting individual development plans to move those individuals to ready within 2 years or to the ready now phase. When we look at ready now, looking at those individuals, we're saying that out of the 188, we have 26 employees that are ready now to move into the next level role.
Now, the no more moves, that is based on their current job performance, or the individual in particular says, I'm happy being manager of such and such?
It could be a multitude of different things. It could be through conversation, two-way communication between the employee and leader. They communicate to their leader that, you know what, I'm comfortable here, this is what I want to do, I do not want to promote up to the next level. Or it could be identified through their performance. You can have individuals that are proficient, and that's where they maintain. They never go down or they never progress up. They just maintain that proficient level.
It's more like subject matter expertise.
Personally, that drives me crazy, but. I'm worried about somebody who's just happy.
But yeah, but that, right, for the number of leaders that were assessed, that's a large number of leaders that are just well-placed, no more movement. So our strategy, when we get around to developing IDPs, we need to put a strategy around, well, when we come back to the table again, that number should decrease. And how do we move them to the ready now box? Yeah, okay.
Dorothy.
Let's pick that box there. The 71, is that 71 people that survey or 71 that fit into that category, or what is that number?
The well-placed, no more moves. So when you look at the very bottom there, when you look at race, age, and gender, so female, that's 71 employees, and then that's 31 male employees that are well-placed, no more moves.
Okay. Any other questions?
I just have a question for you. Just
It's going to be interesting data.
the lady that
It
the
is.
scholarship is named after, will it be?
Brown.
Will it be Brown?
She stayed a nurse her entire time, didn't she?
Right.
She did.
She did.
50.
Good example of,
Yep.
you know, she worked 40 years, she worked here 50 years. 50 years, and she chose to stay in that same spot 50 years.
And to speak to that, it's not a negative,
Right.
but when we look and see that we have 102 leaders that are well-placed, that's a very large number. So what our goal we need to look at is how do we move them forward? And we need to really slice that in half. It's not a bad thing, but we do need to move more leaders focus on, I would say, wanting to progress and to be promoted within the organization.
Okay. Any other questions?
Sounds like raising children at that age. They just want-
Yeah, it does. I agree. Being well-placed and not wanting to do anything else in their life. Once they graduate from high school, that's it. That's all that they want to do. Yeah.
Any other questions?
So when we look at future focus and when we look at this work, we look at what do you see as this person's next role at JPS? The story for this data here and what it's providing to us is that, yes, we see that for the C-suite vice president role, it was recommended 11 futurely will be prepared for that role, but ready now within the organization, we have 4 employees that we feel that could be able to progress to that next level. So when you look at the numbers, that's the number that was recommended for the amount of individuals that could be prepared to move to the next level. But when you look at the ready now, that's where we're able to progress and move those individuals to the next level.
Very interesting data.
It is. It's very interesting. It tells a very good story for us.
Very interesting data. It tells about how well-established we are, how really good we are in having such depth in a lot of areas that we may not immediately recognize. But by taking a look at it, you know, oftentimes it's, well, you know, if I leave, who takes my place? You know, who's going to do these things that I do? And we've got some depth within our organization that can say, we have people who can step in and continue in the same pattern that we have now in terms of forward thinking and moving forward. I just think it's amazing. 188?
188 leaders that were assessed. Okay.
I agree.
It's good.
Exactly.
Okay, all right, okay.
So when we look at next steps, for us, what will occur, this will be phase work. Because what we want to do with this work, we want to be able to conquer this and cascade down to our frontline employees. When we come back in September to present the next phase of this work, we will have prepared the 360 assessment to be able to identify those top performers as well as their leadership assessment. We will, at that time, when we look at those top performers and the individuals that we need to identify to move them to the next level, what our plan is with the executive team is to sit down and identify preparing individual development plans for these leaders. And what the individual development plans will look like is not going to be the leader's responsibility to develop, but it's going to be the leader and the employee developing the individual development plans as well. What does that look like for us? We already have some of those strategies in place. We have LAP 1, LAP 2. We have lead, which is taking the lead, which is going to be for our supervisors and our team leaders. And then what will occur too as well in 2018, we're going to look at additional leadership roles that we need to play and put into place to be able to create and be able to have a well-defined practice in place for our leaders to say, hey, let me take this class in this session to build on my communication, my writing skills. We're wanting to make it to a point to where we have the in-house tools and development processes in place to develop our leaders appropriately. So when we look at this work here, it's going to be quarterly updates, it's going to be quarterly check-ins on those individual development plans. And what we have to remember is that with the IDPs, no two employee IDPs will look the same because everyone has a different competency level, everyone has a different learning level, but it's what is the employee wanting. And what we want to do is see when we look at that well-placed number, we want to see that be a slightly smaller number to move forward, to move those well-placed into other categories to get them prepared for other roles within the organization. So next steps, we'll come back in September to talk about the high performers. Then next year, what we're going to look at is cascading this down to our frontline employees, and we know that that will be a phased approach because that's going to be thousands that we're going to have to work with in getting this developed, and then we will report out on what that strategy will look like, how the learning process has taken place, and what is the difference with that. Has it reduced turnover? Has it increased our engagement? We want to be able to put metrics to what that learning process has looked like for the organization.
Any questions? Yes.
You know the scary thing with all of this? That we could be training a team of individuals to leave us.
Yeah.
Yeah. You're exactly right. Yep. I also, Madam Chair, want to thank Exeter, because Exeter gave us the ability to look at national standards. It gave that, with their database, gave them the ability to communicate with other organizations, both in and outside of healthcare. And writing a succession plan is not particularly easy, but I think there's some statistics and numbers in here that would give us the right direction, and I appreciate Exeter and all their help.
Well, I would like to say, I love the report and think the plan is a well-thought-out plan, and I can see it working, and we probably will prepare some of our employees to do wonderful jobs here, hopefully here, but probably in other institutions. I mean, that's kind of the way it goes, and you want to be proud of that. You look around and say, that person started with, yeah. So sometimes they come back to you. Okay?
Great.
Anything else?
The next report, Madam Chair, we have decided we want to spend a little time and work on that. We wanted to give you guys an update with where we were a year ago. We want to talk to you about the performance and where we've gone. So I ask you if you would not mind, we'd like to pull this report for now. So that we can come back. I think there's some specifics, and I think we've done some things that would be very valuable, and I think we can show the committee that. So if you all don't mind, we'd like to go ahead and withdraw that report from now and then bring that up next meeting or the meeting that you suggest.
All right, I can see us pulling it, and we'll figure out what's the best day, because it's going to be a big report, and it's going to take a little time, and so Pia took all the time today.
She did. She did. Way to go, Pia.
Thank you. No, thank you with Exeter Group. So they were great partners in providing the data. It was a great exercise, and the data tells the story of the work that we need to do with our leadership team, because with our leadership team, we have a great team, but we want to ensure that we're providing them with learnings for their competencies to grow within the organization, so that we can continue to be the best place to work. So that's our strategy.
I'm the only one excited about this plan.
No,
I do not think I'm the only one excited about the plan.
Ms.
All
Dorothy,
right.
I got one quick question. So, I think it's great for the leadership team, but how does that trickle down further so that you continue to, like a sponge, soak up the good from there and bring that group up? How does that happen?
That's the work that has to be done. So we did phase work in this small exercise, but what will need to occur is going to be a bigger phase approach, where like we did the leaders, which is managers, directors, and executive directors. So the next group that we need to focus on is our supervisors and team leaders, and then the next group will be the employees. So out of this 188 leaders that we work with, 267, we're going to have to work with them directly for it to be cascaded down to their employees as well.
Is that part of this $35,000 we approved from finance today?
No, that's Talent Plus. Talent Plus is our onboarding tool that we utilize for new hires. So it's two completely different tools.
Thank you.
Yes.
Yes.
I think this is the part where you got me on the English one. You got minority and then you got non-minority. It's supposed to be majority, but it's not really majority because we have a very diverse group of people, so it's kind of confusing.
What is your question, DT? I'm sorry.
It was just a statement.
Just a statement.
Just a statement about the terms.
That we use was.
Right.
Very much so.
Because when you say non-minority, but it's not really majority either, because like the diverse workplace that we have, so.
Okay.
It's very confusing.
We'll add a definition. It's teasing. Okay, anything else, TT?
One last thing, that's a thing we just want to clear. The one incident is just 1 out of 6,000, so best place to work.
Thank you.
All right.
Always room for improvement.
Okay, we need to reconvene in a closed session just for one item, so it won't be long, but we do have a closed item. Okay. All right, just get out. That was good. That was
good.
really good. That was really good.
Pleased with that
I
report.
think that succession plan will affect the whole institution, and we will lose some employees because folks are going to be looking at it and grabbing them and everything. But I think that for us, it would be a great deal for promoting, staff from within. They'll be ready.
If you're not addressed in the succession plan, you'll know that it's out there.
They're-
And then you get to that group.
Right. I think it's an industry standard, I think. Now, I can't tell you that for sure, but I'll ask. Okay. Yes, yeah.